Well, good afternoon. I am State Representative Paul Baumbach, serving the 23rd House District, which is the north and west side of Newark and up into Pike Creek. And it's time to talk about Delaware State Employee Retirement Healthcare. I've been offering these for most Sundays for several weeks, and it's time for an update. I serve as one of the two co-chairs on the Delaware Retiree Healthcare Benefits Advisory Subcommittee, along with Senator Brian Townsend. The chair is Lieutenant Governor Bethany Hall Long. We had a meeting last Thursday. Our next meeting is this Wednesday. All of our meetings are open to the public, open for public comment. So let's go over some of that. I don't think many people need it, but I'll do a really quick review. In 2021 and early 2022, the State Employee Benefits Committee, the SEBC, with the help of a Retirement Benefit Study Committee, RBSC, looked at health benefit plans and changes to consider. The SEBC voted and approved a change to be effective January 1st of this year, from a current Medicare supplement known as MedicFill for a customized Medicare Advantage plan, which is not the same as a Medicare supplement. And it was announced in early June. It was placed into the budget and voted on by the legislature, signed by the governor at the end of June. It was publicized through the summer. There was a lot of outcry, a lot of public meetings. Subsequently, in September, a lawsuit was filed to stop the implementation. A judge agreed in October and ordered the state to resume the MedicFill, that supplement plan, for calendar 2023. That brought us to January, when the state legislature passed Senate Bill 29, which established the RBHAS and changed the membership on the SEBC, expanded it a bit, and charged the RBHAS with making a recommendation to the governor and to the legislature by May 1st, which is less than 6 weeks away, on what the state should be doing for retiree health benefits going forward. So we've had our two meetings. There's going in, has been a feeling that the Governor Carney's administration is very much backing the Medicare Advantage, the change to Medicare Advantage, and that was reinforced by, in January, the governor put forward his proposed budget that included a paragraph in the epilogue section that called for Medicare Advantage. But then there's a lot of opposition from retirees and retiree groups. And in addition, the legislators, including myself, have heard from a large number of constituents and from retirees beyond the district who are very upset about the proposed change to Medicare Advantage. So, the cat's here. We are, I won't say we're in a camp, but I think perhaps we're showing more sensitivity to the concerns raised by many retirees. So that wasn't terribly apparent in the first meeting, but I think in this past Thursday's meeting, it became more obvious of, I won't say battle lines, but more of alignments and, again, sensitivities. We had, I guess, 2 or 3 retiree members of the advisory subcommittee in person, and in their comments, they shared a lot of concerns with the Medicare Advantage approach and a desire for perhaps a set of options or a Medicare supplement approach. So I'm going to go through a few handouts and we'll go from there. So what you see here is this past Thursday's agenda. It was held in Dover at the State Benefits Office, and we went over approved the minutes. We looked at Medicare options by state. You'll see that in a minute. Looked at how our predecessor, which was the Retirement Benefit Study Committee, what it looked at, and look at the plan for this subcommittee for the next month and a half, and then some open discussion and public comments. I do want to mention that these agendas, which are publicly posted, have all the information for how to join virtually. Some individuals had trouble getting into the meeting virtually on time, and it's believed they may have used the meeting information from the previous week's meeting. So when you're trying to join a meeting virtually, please go to that meeting's agenda and get the information. I'm going to jump ahead to this Wednesday's meeting agenda. The previous one was a Microsoft Teams. This is a Zoom platform. So again, last week's information for how to tune in virtually to this Wednesday's meeting will not help you at all in getting to this Wednesday's meeting. You need to go to this Wednesday's meeting's agenda. So let's go back to Thursday. The handouts are here, and it looked at the. I've shared the view that there are three subsets of people or classes of changes that can be made to help address a nearly $10 billion funding shortfall for the retiree benefits of our current and future retirees. We can put it on the shoulders of the taxpayers. We can put it on the shoulders of current and future retirees. We can put it on the shoulders of active employees, or most likely we can put it on a combination of these three. These, as I've said, these lists are not intended to be, in my eyes, are not intended to be comprehensive, but rather give an example, give many examples of how it can be done. Those, the RBSC, again, our predecessor, looked at these three categories. Now, this was presented, I'm going to come up with an alternative presentation on this in a minute. It's presented of there are states which only offer Medicare Advantage, states which offer both Medicare Advantage and a supplement with the retiree able to choose between the two, sometimes with an additional premium cost, and then those which have health reimbursement accounts so that the retiree can individually choose what Medicare supplement or Medicare Advantage plan they would like to subscribe to and pay for, but with dollars from the state in this reimbursement account. This presentation was challenged by some in the retiree universe. And again, I'll have some of that information shortly. And then some examples of nearby states, those which really offer choices. New Jersey has 4 Medicare Advantage plans, and then also 5 Medicare supplement plans. So again, choice. So you're not forced into what Delaware was proposing was no choice. As of January 1st of this year, what was being proposed was you will have Medicare Advantage or you'll have nothing at all from the state. New Jersey offers many choices. New York offers both Medicare Advantage and also a PPO. It looks like a supplement that pays after Medicare. And there's a bit more cost, $37 a month to retirees if they choose the PPO plan. And then Massachusetts also has an Advantage plan and then multiple supplement plans. So these 3 examples, all of them offer choices. And then here's the work plan for our subcommittee. Again, we have less than 6 weeks in order to come up with our requested recommendations by May 1st. So we have our meeting, we'll go over in a minute what's going to happen on the 22nd. It's really primarily to hear from the public. But then the week after that, on the 27th, review different approaches, including how the Medicare contract was awarded, do some compare and contrast Medicare and Medicare Advantage, look at the group health insurance plan, the GHIP. This is what the SEBC looks at for the funding for all the health insurance plans, both for current employees and for retired employees. And so it's one where this is the effort to measure the costs and the liabilities for this is what has led to the measurement and of the size of the deficit, funding deficit we have there. And then look at different options that we can consider starting for January 1st of next year. Then the first meeting in April, look at what funding recommendations. So this is that, what if we were to change something for current employees? What if we were to do something on the have the taxpayers pay? What if we had some changes to what retirees receive or pay for? Look at the different draft so we start drafting our recommendations, both for immediately January 21st of next year and also longer term. What are some approaches, and including approaches like, do we grandfather current retirees or not? And we have our system has some really notably generous features, and perhaps we can cut them back such that the retiree healthcare benefits don't spring up, don't come into action until the retiree turns 65, even if they retired at 62 or 52. So if they work for 30 years from age 22 to age 52, it is the state responsible for providing healthcare for them for the next 13 years before Medicare even starts. So those are things that are proposed to be examined in our first meeting in April, perhaps on the 3rd. Likely have a second meeting primarily dedicated to public input, perhaps the week of the 17th. I believe the week of the 10th is Easter week. And the week of the 24th, try to finalize our recommendations and then perhaps identify some work groups for ongoing work. So that was the presentations for last Thursday's meeting. In addition, this is that group health insurance and all the different projections, surplus, shortfall, etc. So lots of numbers in there, and these numbers are high because it includes current employees and their dependents and also retirees. So we have a member, Wayne Elmsley, who's a member of the committee, and he represents retired employees of our public schools. And he presented some information. He gave his background, the Delaware Retired School Personnel Association, and he pointed out different ways to address this funding shortfall, and just pointed out that we want to be very sensitive to putting additional costs on those who may be receiving some of the smallest pensions out there, and drew up some lines for those who may be receiving the least, and especially at age. And it was fairly notable of a non-trivial number of people who are receiving pensions who are 100 years of age or older. And one of the issues that was raised, and I talked about this last Sunday, is there's a presentation the state has shared of the cost of the premium for the policy the state has and how that premium is paid between the state and the retiree. And it does not present the Medicare premiums that the retiree pays every month. It's not intended to, but if you don't have that information, you can end up drawing conclusions with insufficient information. So Wayne, in his presentation, did point out the issue of the payments that retirees make every month when they're covered by Medicare, not to mention the amount they pay into Medicare every month that they're employed. Without next thing, it points out that oftentimes a state retiree, well, the reason this comes to light is the presentation the state had shared before is that state retirees pay next to no share of what the state pays for retiree health benefits. Well, they don't for that policy, but they do for Medicare. And if you take that into account, you see that the state is actually getting more paid by the participant, the retiree, for a Medicare supplement than they do for a current current employee who does not have Medicare at all. Okay, so I'll get to questions once I go through these. So that was Wayne's presentation. And then there are members of RISE, which is a group of retirees who came together to fight the state's plan. And they looked at all the public information across the 50 states and came up with a different list. So what you'll see here is the middle column is, I think it's 10 states in the District of Columbia that have Medicare Advantage only. But, again, that's only 10 states, so only 10 out of the 50, plus the District of Columbia. And most have either supplements or supplements and Medicare Advantage with a choice. So for Delaware to move from its current supplements only into Medicare only would really put us in a minority of states. So yes, a lot of states offer Medicare Advantage, but the vast majority of those that do offer it as one of multiple choices. So I really appreciate the work that was done there. And then I want to touch on, again, the agenda for this Wednesday's meeting at 3 o'clock. You can go in person or virtually. In person, you would come down to Legislative Hall, and it'll be held in the House chamber. And we'll go over the minutes, some open discussion amongst subcommittee members, and then go to public comment. We do expect to have perhaps a 30-minute presentation approved in advance from the RISE group, from people who are associated with RISE, on a lot of research that they've done and they'd like to present for consideration by the subcommittee. So, and then we'll also have the normal public comment, presumably 3 minutes per person who signs up. If you do sign up ahead of time, let me see if there's a mention of how to do that. There should be some information on how to do that. I don't see it here currently on the agenda. I'll ask that be added. If you sign up ahead of time, you'll be prioritized and have an earlier public comment and have no chance of having the meeting run out of time before you give your comment. So I'll ask that be added and look for it before Wednesday at 3 o'clock. Okay, now it's time to go to questions. Okay. Can't see the cat. Okay, we got that one. So Henry raises, retirees and active employees are taxpayers who always pay towards their salaries and healthcare through taxes. Indeed. So state employees pay a piece of their salary towards that retirement fund. It's at certainly in hindsight, too low a rate to do a notable job of covering it, but they did pay towards it at whatever the state asked them to. And in addition, current state employees pay towards Medicare, goes towards that. And in retirement, state retirees pay into Medicare again. So yes, there's a lot of ongoing payment there. Jane points out, I need to put this up top. State information seems to be purposefully excluding accurate information. Only 16 of the 50 states offer Medicare Advantage only. Actually, I think it's 11. This is the type of information that really annoys retirees. Most states offer multiple options. Yes, indeed. I hope you saw me present that. I'm going to put back on just my smiling face here as I read the other questions. If the state kept the prior benefits that retirees were receiving and wanted to keep, what's the annual cost? Well, that's what we are doing right now. The judge in October ruled the state could not proceed with Medicare Advantage for calendar 2023 and required the state to take its best efforts to continue the Medic-Fill for calendar 2023. My memory is it's an additional something like an $8 million a month. So since we were talking, so that's somewhere in the order of $96 million a year. Is that a lot? Yeah, it certainly is. But also keep in mind that the state's budget is, I think, above $5 billion a year. So that 100 million is a lot, but it's not a game changer. That said, an $8 or $9 billion shortfall is multiple years of having the state do nothing other than pay that. So where does magnitude matter? But then we're only talking about what the cost, what the difference in cost between Medicare Advantage for a year or Medic-Fill for a year. And I believe that the number is somewhere in the $8 million a month, $7 million a month, something like that, somewhere in the $80, $90 million a year. Current policy affects ESRD patients. So I'm hoping that Catherine can let us know what that stands for. Traditional Medicare will cover dialysis patients with Medicare. CARP has very complicated, nuanced. Medicare can go anywhere in the nation. We're willing to pay more. So Catherine raises the issue that, and many other people have also raised the issue that the Medicare program is, by its nature, national, and that healthcare providers almost universally accept Medicare. And Medicare supplement plans like the Medic-Fill are designed to, you don't have to sign up to participate in it as a health provider. If you take Medicare, you're going to take that also. Medicare Advantage, however, is more like an HMO or PPO where you have a network, then you sign up, you enroll as a provider for it. And especially for retirees, which is unique compared to employees, retirees may live anywhere across the world and certainly anywhere across the country. So a network such as we have for current employees for, say, an Aetna plan or a Highmark plan probably has a big focus on Delaware providers and maybe some, Maryland, New Jersey, and Pennsylvania providers. But it's not going to help you if you're a retiree living in Oklahoma, for instance. So a Medicare Advantage for a state like Delaware, a customized one for Delaware, is better suited for a retiree who lives in and around Delaware than as opposed to one who's moved to Florida or Arizona or Oklahoma or wherever. So that's one issue. And then again, sorry, did we go through more? There we go. And that there's also some carve outs on dialysis services. Let me use this opportunity to say one thing about Medicare Advantage only. And this point was made in the meeting on Thursday, frankly, by me, before public comment began. And this was after we started hearing from subcommittee members. The first meeting, we really didn't hear much from subcommittee members. It was really, just saying, we're here, here's our charge, here's the process, et cetera, now let's listen to the public. So we didn't actually get to start getting a sense on where subcommittee members stood on these issues. And I'm going to lead with my typical phrase I use with legislators, where I speak with subcommittee members. I do not speak for subcommittee members. And we do not speak ahead of time and try to figure out where everyone is. But from the public comments, the comments made in that public meeting on Thursday, several of the appointed members expressed a lot of critical thinking, some asking critical questions and asking for much more clarification rather than accepting at face value material that had been presented in the past by the administration. And I sensed pretty clearly that many of the subcommittee members who spoke up have little or no interest in having a recommendation that includes a Medicare Advantage only approach. I think that my sense is that the subcommittee is very much open, seeking, actively hoping for, and will work towards a recommendation that has choices and does not have Medicare Advantage only choices. So I know that has been a gigantic concern, understandably, for the past more than 6 months. I believe that I'm going to say ship has sailed as far as Medicare Advantage only approach. That's my personal view. And I think is reinforced by what we've been hearing from subcommittee members in the public meeting. And we'll have to keep attending those meetings, watching those meetings, and see if that continues to be the case. The subcommittee has a wide range of members. There's cabinet secretaries from the administration. There are legislators. There are other elected officials, the lieutenant governor, the insurance commissioner. There are representatives of different public state employee unions. There are representatives from each county of individual retirees. So you've got a lot of different, I'll say, camps. But what I've been noticing is a lot of discomfort with what was done before, the decision that was made before, and frankly, the process that was made before. So I know that it may feel like it's a good use of time to point out the weaknesses of what was done before. To me, I'm willing to stipulate that. I'm willing to say what was done before was not beneficial, and I hope that we do not have to do that. We as a subcommittee have the ability with majority to decide what we do. Okay, just had surgery. New York not listed. Interesting. So, Catherine, I'm going to go back to that chart. And New York is listed with an asterisk as being supplements and Medicare Advantage. It's the same plan as active employees. So I can go to that chart there, and you'll see New York there under New Jersey and New Mexico, and the heading is supplements and Medicare Advantage. So New York is listed there. May not have been obvious, but it is there. Let's come back to that old smiling face. Okay. Only 11. Yet Jane points out, reinforces what I noted. There's only 11 states, actually 10 states in the District of Columbia that this analysis notes offers only Medicare Advantage, and indeed that's a low number. So, and Dawn's got a little off topic. Asked about the marijuana bill. There's actually two bills. They were both heard. They both passed the House of Representatives this past week. They both, I believe, cleared the Senate committee and are due for a vote on the Senate floor, not this week because we're off for bond bill committee meetings, but the week after that in the Senate. End of state renal disease. Thank you, Jane, and thank you, Catherine. Yeah, that's not a one that I know. Okay, for Paul, following apples. It applies to people who receive Medicare only because they have kidney failure. For those who are also eligible for Medicare based on age over 65 and who have received Social Security disability for 24 months, the following does not. Catherine, I think that really needs to go offline. I think that's something that's very specific. So how about if you and I through email can address that? Okay. Should not lose my right to make my medical decisions just because I'm terminally ill. Dawn, I'm going to let's stay on retiree health benefits. Obviously, I agree with you on that issue, but let's try to stay in there. And Catherine, no need to say sorry. I'm just trying to make sure that these recordings, people know that they can come and hear about retiree health benefits the state's considering. We're not going to go to other topics. Henry asked, retirees are reaching out to legislators and are being ignored, which makes them restless that they're going to vote for, I assume that's Medicare Advantage Plan, MAP. So I understand that, and I'm sorry for that. So there's 4 legislators, and there are 4 caucuses. There's the House Democrats, the House Republicans, Senate Democrats. Each of those 4 caucuses has a member on the advisory subcommittee. I'm the member appointed by the Speaker to serve the House Democratic Caucus. I will be reporting to my caucus, not this Tuesday, but next Tuesday, on where the advisory subcommittee stands, what it's been doing, what it will be doing, etc. I've also encouraged my caucus members to not hesitate to reach out to me, to forward questions that they're getting that they can't feel themselves on this topic to me. That is my job. I view it. I do not speak for the other caucuses. I do not speak for the other members. That said, while it certainly makes sense to reach out to your legislator and share your views on this, I'd say it's also reasonable to reach out directly to the subcommittee members. So I will encourage you to consider doing that. Let me see if I can go there. Yes, good. Okay, so I'm going to pull up another screen. So if you Google, as I did, Delaware SEBC Subcommittees Materials, you'll come to this page, the meeting materials. And partway down, you'll see the third plus sign, sound minus sign, Retiree Healthcare Benefits Advisory Meeting Materials. And you'll see, did they take it away? They took it away. Who the members are. I will ask that to get put back in so that you can find the names, the positions, and contact information for the members of the subcommittee. The legislators for the House Democrats is myself. For the House Republicans is Mike Ramone. For the Senate Republicans is Brian Pettyjohn. And for the Senate Democrats is Brian Townsend. If you happen to know who your legislator is and which party they're with, then those are the 4 individuals who serve on the committee, on the advisory subcommittee, who really are the point people. Just like on Joint Finance, they're the ones who look at every line of the budget. I do too, that's not in the detail they do. So if I have a resident who reaches out to me on a budget issue, I will pass them on to a member of that budget committee. And I would encourage my colleagues, and I do encourage my colleagues to do the same. So I can't speak for my colleagues. I speak with my colleagues. But the frustration of being ignored, do please keep in mind that legislators get inundated by emails on a lot of topics, as Dawn had raised, asked about the marijuana bills. That was came up during the month of March with bills coming through committee, chamber floors and through committees again, and generated a lot of emails. There's other bills that have come up with a lot of emails. And so legislators can be a little swamped and can take a little while to catch up. And they're much more likely to respond to emails from their own constituents versus from constituents in a different district, House or Senate district. So I think it's always good to reach out to your own senator and your own representative. And for an issue that is in a committee or a subcommittee such as this, also it's quite reasonable to reach out to the members of that specific subcommittee. So again, myself, Representative Mike Ramone, Senator Brian Pettyjohn, Senator Brian Townsend are the 4 legislator members of this, along with the Lieutenant Governor and the Insurance Commissioner and 3 cabinet secretaries and several retirees and some representatives of unions. Okay, let me see. To reach out, Catherine. In the new plan, I would like to see ESRD patients be able to opt into their federal carve-outs in traditional Medicare Protect. Maybe that's a product. So again, Catherine, let's go offline. That's a very specific issue that I won't be able to resolve on this Zoom call. 16 to 15 states have Medicare Advantage as their only option. Again, I think it's only 11. More than 23 offer a paid-for supplement plan with other options. Indeed. So yes, it is very true that while Medicare Advantage is available in many states, it is not the only option in many states, rather only about 10. And supplements are much more widely available. Frankly, I don't want to sort of play that game in case over time more and more states offer Medicare Advantage only or offer fewer Medicare supplements and say, well, because they're doing it, we have to also. I think we really should focus on the merits of what we're considering. And if we find insufficient merit for Medicare supplement, then we should offer it neither as the only choice nor as a choice. So, and I think that's one of the things that the subcommittee is looking at is what options have the most merit. No problem, Dawn. I'm sorry about that. So it's only 10, 11 county DC. I'll bring up the chart again with the listing of the plans. No problem at all. So the Medicare only is this middle column. Alabama, Arizona, Colorado, DC, Georgia, Illinois, Kentucky, Louisiana, Maine, Minnesota, and New Hampshire. So that's a total, sorry, come down here, a total of 11, if I remember correctly, and that includes, where's my mouse? That didn't do very well now, did it? Let's go up there. Let's go there. So that's a total of 11, and that includes DC for Medicare Advantage only. So if you take the left 2 columns, supplements only, including Delaware currently, and supplements and Medicare Advantage as a choice, you add those 2 together, you've got 38 states. So a vast majority offer supplements and Medicare Advantage or supplements only. So the numbers are currently very strongly in favor of choice in supplements over Medicare Advantage only. Okay. Let's see. Yes, and this, I should say, this research came from, I think, Barbara Philbin, and we are expecting to hear on Wednesday from some members who work with RISE and done an awful lot of research, so we should get more research. The state should be concerned about keeping teachers and other employees. If you offer them trashy benefits, they'll leave, teach in a different state. We're already losing teachers to other states. On that point, Jane, in particular, the governor's budget includes, I believe, a 9% pay raise for state teachers because there was a study done of how our salaries for educators compares to our surrounding states, and they found that teacher salaries, in particular, were notably lower than our neighboring states. So a 9% one-year raise is tremendous, but it's tremendously needed. It was also found that the other levels of employees in our schools, such as bus drivers and maintenance workers and those who work in the cafeterias, et cetera, were nowhere near as imbalanced compared to our neighboring states. So it was a very, just for teachers, big increase, and then a smaller increase for the other employees in our schools, in our public schools. So, so Kevin asked, by supplements, do I mean Medigap policies? Yes, indeed. Supplement is a term I use to say it's a policy that sits on top of Medicare. You can say it's the gap between Medicare, and you don't want to have to. The third part, there's three payers. First one, it goes to Medicare. Whatever they pay, they pay. Whatever's less goes to your supplement plan if you have one, and whatever's left goes to you. So you'd like those first two to cover as much as possible. Sometimes that supplement is called a Medigap plan. So I will use those terms interchangeably. Medicare Advantage is a different setup, and it goes in and it replaces, if you will, Medicare, traditional Medicare. So the payment, the charge, the bill goes to whoever's administering the Medicare Advantage. They pay whatever they pay, you get the difference. And Medicare, since it's not paying directly to the healthcare provider, is paying the administrator of this. In this case, if we'd gone ahead with the plan, it would have been Highmark. So it's a different model, different design. I would not call that Medigap. I would not call that Medicare supplement. I'd call that Medicare Advantage. Very good questions, comments. I hope that this is useful. I want to remind you, if you can, next Wednesday from 3 to 5 will be the next meeting. It will be predominantly public presentation and public comment from retirees and members of the public. We'll have a little bit more, I'll say, business, but a vast majority will be on public input, public comment. So if you're interested, please join either in person or by Zoom. And let me see, it has to have 26,000 in order for it to operate within the state options. Will not support that. Does not make the present administration happy because they keep pushing. So Henry raised the issue that Medicare Advantage pools, groups have to be at least 26,000 participants. I haven't seen that said. I'm not saying it's right or wrong. I'm just saying I haven't seen it. And given we have a total of something like 32,000 people covered by our retiree health benefits, if we offered any choice, that would likely make Medicare Advantage not something that we could even consider. That is a question that that's a question that I raised on Thursday to say, are there, if we cut it into choices, would we be limited because of the size of our pool? And I was told directly by our consultants that with 32,000, we've got enough people that we'd be able to have some options and still get reasonable pricing on a per person premium level for that. But what if there is a 26,000 hard limit, a minimum number of people to be covered in order for Medicare Advantage plan to provide that? I had not heard that before. I think we're coming to the end of questions. I generally aim, that was said at the Goldie Beacom meeting. Thank you, Henry. I really appreciate that. I do plan to hold this on as many Sundays as I can. I will probably take Easter off. But please don't hesitate to email me. My email is at the top of this discussion thread. And please consider reaching out to any member of the advisory subcommittee. Again, I want to emphasize, the advisory subcommittee has only less than 6 weeks to make its recommendations, and I think these recommendations are extremely important. I would like to encourage everyone to be focusing on the present and future and not the past, because the subcommittee has to make recommendations about the future. We've all heard all the criticisms about the past, and I think most of us embrace that. We don't need to wage yesterday's battle. We have to look at tomorrow's challenges. Tomorrow's challenges is, what do we offer retirees in the future? So let's focus on that. Let's try to be as productive as we can and help us make the best decisions we can by May 1st. That's my request. That's all it is, just a request. But with that, I think we're ready to shut down. Again, thank you for your interest. Obviously, a lot of you are like, there's no choice in the matter. This is perhaps overstated, perhaps not. This is life and death. You have a reason to be very, very involved, and that is very good. I appreciate the input, the passion, the thoroughness, the personal time that's been devoted to this, and hopefully all this we can harness and come up with the best process, the best procedures, and the best program for the future, for retirees in the future. With that, I hope you have a very good rest of the weekend and a good upcoming week. Take care.